Good evening, everyone, and welcome to the National Humanities Center Humanities in Class webinar series. Tonight's pop-up edition webinar is titled Putting Coronavirus in Context, the History of Disease and Epidemics. And I'm joined tonight by a history professor from University of Pittsburgh, Mari Webel. It's funny, we work hard when we put these schedules together to try to find topics that are relevant to your curriculum, but I think also topics that are relevant to just the daily conversation that you're likely having with your kids. I often, when I talk about the humanities, I try to position them as disciplinary lenses to understand the complicated world that we live in, that the humanities actually help us make sense of things. And there maybe couldn't be anything more topical or present tense than tonight's topic. As a matter of fact, in a very personal, first-person way, I was scheduled, Libby and Mike and I, shown here on the screen, were scheduled to fly to Los Angeles tomorrow morning, 6 a.m., non-direct direct flight to Los Angeles. And we had to cancel that trip because of not just the virus itself, but the responses and the disruptions, and some might say even the panic of the virus. And so I suspect that as your students stream into your class, whether you're in other parts of the country that haven't been affected yet, they're going to be talking about this. And there's a mental model, there's a roadmap in their minds from popular culture and movies and the news and their parents and people talking that you have to, in some cases, unteach as much as teach. And so last week when we decided to do this pop-up edition webinar, we thought it was important to offer you resources and knowledge and talking points to contextualize the current coronavirus and to put it in the context of past diseases and epidemics, and to do so not necessarily from a medical perspective or public health perspective, although we may or may not touch on some of those issues, but really to do one from a humanities perspective. And I hope tomorrow that all of you are able to take the conversation we're about to have to your students, whether it's in the hallways or at the lunch table or in your class itself. As always, I want to thank Libby and Mike for being a big part of our team, but also thank each of you for joining us tonight on this quickly scheduled webinar. We've got folks from literally all over the country. Angela from Delaware is with us tonight, Marty from Ohio. We've got Kate all the way out in Boise, Idaho, but she's sitting side by side with Marie from Georgia. And of course, this is the first time in quite a while I remember someone from Puerto Rico joining us. So Andres, thank you so much for joining us. One of the advantages of this online format is that whether there's a virus and a lockdown or not, that we can sort of join each other and talk in this digital environment in the evenings, and to work closely with lead scholars like Mari. In some ways, that's what the National Humanities Center is intended to do. Rebecca Simmons joined us this past week for a workshop here at the center and saw that it's intended to be a laboratory for the humanities. We're located in Durham, North Carolina, and each day we get a fellowship class of humanists, humanities university professors who come to the center and they do their work. Our education department then is intended to connect that scholarship and scholars like Professor Weibull with educators at all levels, so we can talk about and create innovative new ways to explore the humanities. It may well be that you aren't near or able to join us in person in Durham. You might be Anna in Carmel, Indiana. If that's the case, you can access all of the work that we do through our website. We've spent a lot of time in the last 6 to 8 months indexing it and creating a metadata tagging system that allows you to find all of the content that we create in both the scholarly programs as well as our education programs. So if, for example, tonight you go to our website and you go to the search bar on the left-hand navigation and you type in disease, you'll find what in fact is the single most popular, meaning the most visited and the most accessed online resource we have in education. It's a document in our Native Americans and Land collection titled The Columbian Exchange, Plants, Animals, and Disease Between the Old and the New Worlds. So you're able to search by keywords, and it may well be that after tonight's webinar and the recording that follows it, that you want to search for other resources that are very similar, and I'd invite you to do so. A couple of quick announcements before we get started with tonight's session. First, I want to remind you that we did have to reschedule Luke Bovens and his webinar titled Teaching Ethics with Short Stories. Instead, that is March the 10th, and because we rescheduled it, as you may remember, we had really bad, severe weather in North Carolina at the time. We have to reopen the registration, and currently there are 84 seats available, and so I'd encourage you to sign up. I think that's the only session that has any openings right now. I'd also like to invite you to apply for our Teacher Advisory Council. Applications will be open on March the 13th. I see many of our TAC members in the room with us tonight, including Lisa Pennington in Illinois and Karen Baranek up in Bering Strait, Alaska. We would love to have any of you who spent a lot of time with our webinars and other materials to join us in this council. It's a one-year tenure, and it does include a two-day summit at the National Humanities Center, in which we fly you in, bring you in to learn more about the center and the work that we do. I also want to remind you that our online courses are currently open for registration. We put out an announcement earlier this week, but I think it's important to remind all of our LAUSD teachers that the district has approved our online courses for one salary point. So one course equals 5 webinars. And if you are interested in taking a course, we have a few seats available still for all 5 of the courses registered starting next Monday, March the 9th. So please visit our website to follow that registration. And then finally, I'd like to invite each of you to consider joining us at the center for a 5-day summer institute titled Beyond February, Hip Hop and the African American Experience. What I'm finding is that many states, perhaps your state, is rewriting their curriculum, their state curriculum, to be more culturally inclusive. And probably a lot of you are going online and you're doing Google searches and you're doing your best to put together packets of resources or digital collections of resources that allow you to access these ethnic voices. This session is intended to use hip hop as a tool to do that. This is not a history of hip hop session. This is working with a performance artist, a professor of hip hop. A.D. Carson actually did a webinar for us last year to really understand how music can explore key themes of the African American experience and then translate those into instructional materials. And so we'd love to have each one of you consider joining us. This 5-day institute will be the last week in June, and we are limiting participation at 36. I've been working hard over the last week to find scholarships for educators to attend this. I think it's going to be a really powerful week. And I have secured scholarships for educators who currently teach in the following areas. And I know that does apply to some of you in the room tonight. We have been putting this on social media. It is on our website. I'm also working with your district administration to promote and to distribute this information. Currently, we have full scholarships available for teachers in the District of Columbia, in Philadelphia schools, in Decatur Public Schools, which is A.D. Carson's hometown, in Charlottesville City Schools, that means you, Christine Esposito, Charlotte Mecklenburg, as well as Los Angeles Unified. And so if you're a teacher who'd like to join us, we have a full scholarship that will be awarded after an application process that is currently open, and I invite you to go to our website and see the details of how to apply for that. At the center, we've also we support early career teachers. So we have a scholarship for North Carolina educators who are in their first, second, or third year of their career. I hope to be adding more scholarships to this list. I've been identifying different areas around the country. If any of you are interested and not quite sure that your district or you have the money to pay for the tuition, I'm happy to work with you to talk to donors or foundations in your hometown. I can tell you that many school districts have education foundations that support teacher advancement like this. And please keep an eye on our website for additional scholarships as we announce them in the coming weeks. If you have any questions, please email me and let me know. Finally, our webinar tonight is a very interactive experience. Professor Webel and I will be discussing her work and the slideshow that she's presented and put together for you. But your participation is going to be very important, and that means using that chat box to ask questions, to share ideas, to respond to some open-ended thoughts that we may have. Please do speak to us directly as well as each other. And I hope that chat box becomes a place of good conversation. Thank you for being patient with me while I introduce Mari Webel. Mari, just turn on your microphone. Mary, when I used to work with graduate students at University of Virginia, I would sometimes joke in the history department, I would sometimes joke that what they really need to do is forward think about 15 years on what topic is going to be the most important. It was, this Civil War for a while, it was World War I, and now you must be the most popular historian in the world.
Not quite, and thank goodness. But it's an interesting time to think about the things that I think about on a daily basis, and to be interested in the stories that I care about. So the fascinating thing for me has been that it's not just colleagues, but also now I have relatives who are getting in touch and asking me for context, and it's generating some really fascinating experiences. So I'm so very happy to be with you tonight.
Great. Well, thank you again for joining. We did this, we literally did this on as fast as we could. I think you were able to find a sitter for your kindergarten age
Got him. Yep.
daughter, son. You sort of rearranged things. You decided to join us in just a few days' time, and I do appreciate you spending time with us. I'm going to give you the mouse in a moment and let you walk through this context and sort of share with us your perspective. But if you don't mind, I'd like to actually start with a question of my own. And
Sure.
in some ways, this is to sort of frame things, but it's also in the context of what I think many of the educators with us tonight are facing, which is kids walking in tomorrow. My son, who's a junior in high school, is going to walk into his high school tomorrow and say, my dad was supposed to be in Los Angeles and he can't go because. And whether it's in the curriculum or not, it's on people's minds. And it's also because of slides like this, right? There are live action sites where you can track the virus. When you see something like this, and I talk a lot to scholars and humanists about the ways they see data, when you see that as an historian, and that was saying, I took that screenshot an hour ago. Tell me what you see there. What is it that, how do you start to see around the edges as an historian?
My first gut response, my hot take, and this has been to a couple of the maps, is we had to go and make China red.
Yeah, right.
That there are a lot of different ways to depict data and to depict the seriousness of data, and red is this sort of emergency sign for us. It's the stop sign. It's the flashing light, and so I think it serves to attract attention, but it also focuses one on a particular site as quite literally a visual hotspot in a way that I think doesn't really speak to the full social dynamics of what is going on globally right now. So that's one sort of initial response. And the other thing, and this is something that when I'm teaching the history of public health and talking about different maps and ways of visualizing data, even on the best, most ideal kind of depictions of different burdens of disease or causes of illness from, say, the WHO, you always have some sort of lighter shaded or gray areas. And that usually means nothing reported, right? Or do not have data. But from my perspective, given the dynamics with this particular epidemic, these sort of dark grayish bluish areas globally, or the ones that are shaded in a paler color, are that's something that's kind of my next question is, well, how, given what we do know we know that there's nothing in, say, Egypt or nothing in another place where we have flights connecting people all the time? So yeah, that's my first sort of take is to that this is a useful thing to think with, and it's interesting to think about where our dynamics are, but also important to not let this push us to any sorts of kind of panicked conclusions about places or people.
Yeah, I'm going to actually underscore that for a moment. I've handed you the mouse, and we'll go on with your session. But whatever the antidote is for panic, I think you just kind of nailed it, which is this is a helpful tool. But when all these kids stream into all these classrooms tomorrow, there is a context that helps make better sense of this than just look, Gwyneth Paltrow. We know how the movie plays out, right? So there's so many ways to kind of read this that we can as
Yeah.
educators can try to unteach in kids.
Yeah, yeah, absolutely, absolutely. I've been doing a lot of work on that lately. So just by way of introduction, in terms of what you're all going to be seeing and hearing from me tonight, where that's coming from, I'm currently teaching a course called Health Controversies in History, which is a 75 student big intro course for history, not for history majors, for all majors within the university, that is oriented around different things in public health historically that have caused tension or social disruption. And I do a unit on quarantine, a unit on vaccination, and a unit on health and heredity. And I was 2 weeks into the unit on quarantine, just in the process of teaching the advent of quarantine and the bubonic plague, when we started to see these first reports about what we were then calling the novel coronavirus. And so this has been my bread and butter in my everyday for a while, but also something that I'm really committed to trying to give students from a variety of different interests the tools to make sense of. What I talk about with my students is that we all right now really have to learn to be better consumers of information, and particularly of scientific information that may be less familiar or require a little bit more attention than usual, because that sort of learning how to process and learning how to read studies and learning how to parse news reports is going to be a very important part of how we communicate with one another, and also help fight misinformation, help advance correct information amidst this ongoing issue.
Which is pretty amazing because that's what the humanities do. And
Yeah, yeah,
right,
absolutely.
in a health crisis where the scientists sort of take, I'm going to back you up there,
Sorry.
uh, where the scientists sort of take front and center, it's
Yeah.
the humanists who are going to help us make sure that we handle this correctly.
Yeah, I think absolutely. And I mean, one of the things that I pay a lot of attention to as a historian is the ways that people talk about things and how those relate to the ways that people in the past have talked about things or how they have reacted. And one of the things that you'll see in the course of what I have to offer for tonight is that I can see, and other colleagues and scholars have written about this as well, I can see some pretty clear lines of connections to the way that people have been talking about, for instance, origins of disease in China, and the way that 19th century Americans, particularly in California and in the American West, responded to Chinese immigrants and the third pandemic of bubonic plague. I think that the responses right now to thinking about this as a global epidemic have a lot to do with the way that we talked about the discourse around Ebola virus disease in 2014, 2015. And of course, one of the main touchstones that we hear from pretty much everyone regularly is comparing COVID-19 to influenza, whether seasonal influenza or past pandemics of influenza. And one of the things that's really a challenge right now for scientists or humanists or social scientists is to figure out how far and how useful those analogies are, what they can teach us, where they might misdirect us in different ways, but how to ask good questions about what's happening. And that's what I tell my students continually. I'm not going to have all of the answers for you about anything necessarily, especially about public health, but I can teach you the kinds of questions to ask in the future that will hopefully equip you to be a critical and engaged part of any conversation or policy-making decision or care decision that you might find yourself in.
Oh my God, am I going to take that snippet right there and put it on a bumper sticker? Because that is beautiful. Thank you. So I've given you the mouse. Please lead us on the conversation. And my job as the moderator is to bring in any questions from the audience and ask for some clarifications and try to keep that moving.
Sounds good. So, hello all. I wish I could see you and wave to you, but I cannot. I am very excited to hear your questions. I run my lectures and any of my talks in a sort of interrupt me as you need to fashion. So I'm probably not going to be keeping as close of an eye on the text box because I'm also reading and working from my own materials. But if you need a point of clarification, please don't hesitate to ping that into the text. I've structured this around some key case studies that also touch on broad themes historically. And that these are case studies that I've found instructive for encouraging students and readers and colleagues to think about the importance of past experiences and of past cultural contexts, of different cultural contexts, in how we think about public health and these ongoing epidemics. We may not make it through all of the cases depending on how the question and answers go. I will say, as an aside, I opened this up to my students today and we spent 25 minutes of a 50-minute period talking about coronavirus and not talking about polio eradication. So I'm sort of ready for that. But I will also include some classroom materials as well for you to use. So, so to start us off, one of the key things that I think, these are some broad starting questions. These aren't things we're necessarily going to answer, but these are the priorities that I think are before us as educators right now. How we put this current situation into broader perspective, both in human history, in the long view, as well as with regard to past epidemics that are often used as analogies. How do we understand and communicate the similarities and differences between this current situation with COVID-19 and other historical epidemics? And when I say to students and the wider public, this is something that I prioritize because the students are going to talk to their families, they talk to each other. We're sort of creating pathways of information and of critical thinking constantly. Another thing that I think is really important right now as students are thinking about what a self-quarantine means or what social isolation means, how do we put disease prevention measures into context, help people to understand their origins, how they've been used in the past, how they're being used now, and how there might be differences over time. And then also, and this is really front of mind for me, improving critical thinking and open communication, addressing racism and stigma directly and effectively, as well as addressing misinformation in the current moment. These are again things that humanists can do really beautifully, but that we can all do. I think everybody can do well and do better, seek to do better. So some grounding perspectives and big themes. So these are things that when we're trying to understand the current moment, I think these are really crucial. So COVID-19 and other coronaviruses are zoonotic diseases. Zoonotic diseases are diseases that have jumped from animal species into humans. Zoonoses is the other way to think of this. These are significant in human history and are old in our human experience. So while we hear a lot about, quote, emerging diseases or about novel diseases, these sort of new spillover events, this is the stuff of movies. These are actually things that have been with us for a very long time. And so I'll walk you through some examples of that in the broader epidemiological perspective and deep human history. But that's something that I think is an important thing to remind people. The second is that the disease prevention tactics that were founded in the past, grounded in the past, are still with us, but they are evolving consistently. So what we mean when we say quarantine now is different than what medieval Europeans or medieval Venetians meant amid the Black Death, even though the word is the same. And how do we help people to understand what those differences are? And then lastly, when we're thinking about how public health responses have been directed, but also how popular engagement with public health interventions. So when I say public health intervention, I mean any kind of project or program that a public health department or public health officials might try to implement in order to keep something from happening or to make something else happen. So vaccination campaigns are public health interventions, but so are isolation measures or efforts around sanitation to clean water supplies. But to keep in mind that stigma and discrimination and racism have played a role in past public health responses and in public discourse around public health. And that is, of course, because public health responses and public discourses are culturally embedded, right? The society and the political system, the economic system, ideas about race, ideas about gender are sort of baked into the way that a given society will manage a crisis that threatens health and wellness. So these are things just to sort of keeping in mind. There are elements of what is happening right now that are worrisome for us on a personal level in terms of our own health, but there are also things that we are seeing, anti-Chinese and anti-East Asian, vaguely East Asian discrimination and stigmatization that are disturbing for us at a social and cultural level. And so these are things that I'm working with and thinking about. So I'm going to start us off with this is just a quick run through of the kinds of case studies that I'll be talking about. So I'll talk a little bit about epidemiologic transitions in zoonotic diseases. I'll talk about the advent of quarantine amidst the bubonic plague in the 14th century. I'll then zip forward to cholera in the 19th century and the advent of international coordination around health. Look at bubonic plague and anti-Chinese racism in the US in the 1890s, pandemic influenza in 1918-19, and then talk about SARS and Ebola as more recent touchstones. So those first 4 bullet points are really going to be about the sort of foundational moments that gave us particular institutions or techniques, and then these last 2 are more about modern touchstones. So Rashida Smith, who I see you've just posted a question about 1918-19, and I will try to do as much as I can to get to that that moment probably around halfway through. So zoonotic diseases are not new and they are not unprecedented. This is a lovely graphic about zoonotic diseases from the CDC. We have, since we started interacting with animals, managed to pick up diseases from animals. Zoonotic diseases are diseases that can be transmitted from animals to people. We sometimes think of these as diseases that normally exist and circulate in animals, but that can sometimes impact humans. And we had a Paleolithic transition, and this is in deep human history, so between 8 and 10,000 years ago. Our human ancestors moved from nomadic transhumant foraging to sedentary agriculture. And when we settled down with animals around us, goats, sheep, pigs, cattle, different fowl species. We also settled into larger cities, larger towns, that led to different kinds of issues with sanitation and the transmission of diseases. But when we're thinking about zoonotic diseases, tuberculosis was an early zoonosis, anthrax, brucellosis was another one. We saw zoonotic parasitic diseases, different kinds of intestinal flukes, different kinds of intestinal parasites. Plague, Yersinia pestis was another one that was a vector-borne and zoonotic disease. So this transition to sedentism in food production, which allows really phenomenal cultural production, political organization, social stratification, lots of different things, also involves new kinds of diseases simply because we start to keep animals around us more and more. In the modern era, if we sort of think about how they are characterized in the modern era, these happen, they are frequent, they are sometimes serious and sometimes not at all serious. So there are, one of the coronavirus experts that I've worked with here at the University of Pittsburgh for a teach-in that we did a couple of weeks ago, really worked to emphasize that coronaviruses are not all causes of serious illness. Some of them cause what we would think of as the common cold, but they also are illnesses that move, viruses that move between people and animals regularly. So when we're thinking about,
let me ask you a quick question.
Sure.
So I'm going to go back to that to ask this question. So I heard you say, I heard you use the phrase serious. I'm sorry, what was the phrase you used? Sort of the metric of this being serious. You said some are serious and some are not.
Mm-hmm.
How do you, in this context, how do you measure serious?
Sure. Oh, that's a great question.
Illness, is it death? Is it?
For me as a historian, I'm not thinking about case fatality rates necessarily or morbidity rates. For me, serious illness is the kind of illness that takes you out of your daily life, right? Or that causes death, that causes significant illness. That's something that we start to notice and to worry about as a human infection, and not kind of chalk up to, oh, stomach virus, or oh, runny nose, right? So these are the sorts of things that start to surface in reporting, or that become consequential for thinking about human disease. So that's my metric in serious and not. Right. But I think of the common cold, however annoying, as not being something that is a serious medical problem for the majority of the population, right?
Thank you.
That's my distinction. Thank you for asking about that.
Sure.
So one of the things that I wanted to sort of walk through is this question about the Paleolithic baseline, and this is within a broader framework of thinking about the long sweep of human history, and what we think of as epidemiologic transition, which is to say that different societies, different human populations in the past have dealt with different kinds of diseases over time, and those have changed over time according to different kinds of social organization, domestication of animals, industrialization, and so forth. In order to get more into the cases, I'm not going to get deep into this process of epidemiologic transition, but I just want to flag that this is a sort of theory that's advanced within public health, but also anthropology and physical anthropology, as well as cultural anthropology, to be thinking about the kinds of different things that have caused disease in the past. So, for instance, from what we know prior to the 6th century, we didn't really have widespread disease caused by the Yersinia pestis, bubonic plague. Prior to the 1890s, bubonic plague was really isolated in Eurasia, a little bit in Africa that we know of, but mostly in Eurasia. It wasn't something that we were really worried about in endemic form in North America, for instance. So we've seen a lot of different transitions in terms of the kinds of diseases that we deal with. And one of the articles that I'll give you for advanced reading engages with this more directly. But in the interest of case studies and time, I want to keep moving to thinking about plague. So when I teach the history of disease, because I'm kind of a science and medicine person as well as a historian, I always start out with basics of transmission. So plague is important for our story because the early outbreaks of bubonic plague in the 14th century in Europe, what was later called the Black Death, give us the institution of quarantine. So just a quick primer on when we're talking about plague, what we are talking about. Plague's a bacterial infection. It has a short incubation period, really acute and dramatic symptoms, fever, weakness, nausea, aches, you feel terrible, and these very characteristic swollen glands that were called buboes that then can blacken and separate and swell up and are teeming with those plague bacteria. There are 3 forms of plague. The same bacteria has different presentations in the body and routes of infection. So bubonic plague is spread by the bite of an infected rat flea. Pneumonic plague is spread in the air, and septicemic plague is a blood infection. It's a serious disease, or was a serious disease historically. Case fatality rates, mortality rates between 30 to 60%. Almost all of the people who got pneumonic plague died historically. So this has been an important cause of illness and disease, and a really scary disease in human history. When we talk about plague, we are generally thinking about this what we call the Black Death. Now, fascinatingly, it wasn't actually called the Black Death at the time, but rather the Big Death or the Great Mortality. And this is generally what we refer to as the second pandemic of plague. The first one was in the 6th century, called the Justinian Plague. And so at the time, this big death or this great mortality is significant. Now, you will probably have heard casual references to someone saying like, oh, is coronavirus going to be the next Black Death? Like, what is this going to be like? Nothing that we are seeing right now points to any kind of similarity to the Black Death, and that's in part because the Black Death was a really specific event, and plague has a very different profile in terms of the way that it operates in human populations. So when we're making those comparisons to the Black Death and making comparisons to historic forms of mortality, we have to think about what made it so bad in the 1340s. So the 2 maps that you see here map the transition of plague from its historic origin points in rodent populations, marmot populations in Central Eurasia, across the Eurasian continent and into Europe and North Africa in the 1340s. What we see in this moment is that plague is really devastating, in part because this seems to be a very virulent strain of plague, of Yersinia pestis, but also because of the conditions of medieval life. So it's important, I think, as humanists, as historians, to be thinking about why diseases are what they are at different points in history, right? And to answer Angela's question, the Justinian plague was also Yersinia pestis. Yeah, we're always talking about Yersinia pestis.
So Mari, if I can underscore again something I
Yep.
heard you say that I think might be helpful for our teachers.
Yep.
It seems as if the language, particularly the language of analogy, is really important in the ways that we talk about things like this. And so whether it's I don't know that media reports have done this, but certainly sort of in the hallways, people might say, is this the next Black Plague?
No,
It sounds like what you're suggesting is you can
no,
definitively say, nope,
no, it is not.
that's not fair at all. And
No, it's not a fair comparison.
you're alluding to something that just is not accurate.
Yeah.
Okay.
And this great mortality, the Black Death, was so devastating in the 1340s. I mean, it had these really high mortality rates because it was newly virulent, but also because of the conditions of medieval European life. Medieval European life, I would not go back to medieval Europe. People always ask me when the best time to live is, and I'm like, I'm good with right now.
Right now.
I'm good with right now. I'm a woman who's a professor, like right now sounds good, even though there are a lot of things I would still like to fix. I would not want to go back to medieval Europe. I would probably have been long dead. So dense settlements, close habitations, overpopulation, but particularly in the late 1330s and into the early 1340s, consecutive seasons of very poor harvest, resulting in famine. Exactly, Carol Pixton, yes. So widespread famine, the population was vulnerable, was weakened and was vulnerable. One of the things that also happens in times of famine and in dearth is that people tend to sort of cluster closer together. They prioritize survival, and so it was a really difficult time. So it is such a moment because people's constitutions were weakened. They were not robust. They got sick and died quickly, and because it was also strongly associated with this sort of close quarters. Now, because this is a disease that's spread by rat fleas, and people are sort of living with and around rats all the time, this is another thing that contributes to the spread of this disease. As people move, the fleas move with them. So it was possible to have infected fleas that carried the disease in clothing, in bales of fabric or cotton, or in goods and so forth, regardless of whether the rats were there. And that also could spread the disease. So when we're thinking about the bubonic plague, we have this great epidemic in the 1340s, so 1348 to 51 in Europe, that leads to, and again, this is a map of the spread, that leads to dramatic mortality in Europe. Somewhere we estimate somewhere to, I think, 1/3 to 1/5 of the adult European population, or excuse me, 1/5 to 1/3 of the adult European population dies amidst this epidemic. But one of the things that we don't often think about is that plague continues to circulate, right? So there are a lot of responses to plague at the time that involve stigmatization, for instance, of European Jewish populations, charismatic religious movements that are attempting to sort of make amends for this visitation of God's wrath within the frameworks of the time, and so forth. But plague continues to circulate in the 14th and into the 15th and 16th centuries. And so societies respond to that by imposing quarantine. The early quarantines, or the institutional quarantine, was something that was developed out of traditions of isolation and separation. So medieval societies would regulate burials, sometimes ban religious gatherings. Then they developed a set of routines. So moving people into places of isolation for the sick, such as leper houses, banning people from entering or leaving a city if illness was known, and then finally forcing travelers, to undergo a waiting period before they were allowed to come into a city. Now remember, medieval city-states governments are smaller units. This is an international cooperation, but rather on a kind of ad hoc basis. So the picture that you see here of the buildings kind of in the water is the Lazaretto Vecchio in Venice, which is the old Lazaretto. The map below is a drawing, and the two spaces in red there are the new and the old Lazarettos outside of the city of Venice in the lagoon. Some people say that these Venetian Lazarettos were the first quarantine stations. Others say that Ragusa, which is modern Dubrovnik in Croatia, were the first to institute these formal waiting periods before people could enter into a city. And it was initially 40 days, which gives us the quarantino, that question. So we start to see these medieval city-states and governments paying attention to ships, paying attention to travelers, paying attention to the sick and the well locally in order to try to stop the movement of infection. And this other picture that you see, the black and white photograph, is a picture of the Lazaretto quarantine station in Philadelphia, built in the 1790s, a photograph of that. And you can see the sort of piers and the wall and a building in the center that would have funneled the sick through this sort of space in order to keep them from spreading out into the wider population. So,
quick question, yeah. Professor, from Trip Franklin. He asks, yeah, how does temperature affect, if at all, epidemics or the transmissions of diseases in the past?
I wonder, I guess, Trip, are you thinking about seasonal transmission of diseases? So sort of winter versus summer, or thinking about what specific aspect of it, if I can ask you to chime in?
This will give you a chance to pause for a moment. There we go.
Winter versus summer. Yeah. So different, I guess there's no hard and fast rule, but we know that different diseases circulate in different kinds of environmental conditions in different places in the world, right? So some diseases are diseases of sort of rainy and cold, damp air. Others spread more readily when it's hotter and drier. The vulnerability of a population often doesn't have to do with season, but rather with a person's health status or what they sort of have access to, nutrition and so forth. But those seasonal dynamics that we think of as being important with influenza, right? So we think about the winter being our influenza season in the Northern Hemisphere, aren't consistent across diseases. It really depends on which kind of disease you're talking about.
Great, thank you.
Yeah, no, thank you for that question. Quarantine periods change over time. Yeah, exactly. So perfect. You're anticipating where I'm going. Great. And I would love to talk to your Alaska teacher about the documents on the permafrost with flu, because that's absolutely something that was really important. So one of the things that we see with quarantine periods is that they were 40 days in the 15th century, in the 14th and 15th century. But one of the things that we see public health officials doing in the present day is adapting those quarantine periods to their understanding of a period of infectiousness, right? So when people talk about a self-quarantine for 14 days with COVID-19, in my understanding as a historian, it is because they are thinking about the sort of period of the incubation period, the period after which somebody becomes infectious. So when you know, for instance, that a disease is going to take between 2 and 10 days to develop symptoms, and that happens in the standard cases, then if a person clears that 10-day threshold, they're likely not going to develop symptoms, and so they're not infected. So that's what it's oriented around in terms of how we think about it. But one of the things that I want to point to about quarantine, since human societies have used quarantine and isolation measures, they have always been social in their dynamics. And this is something that it's just, you sort of have to orient yourself around this. You're thinking about targeting particular people with particular public health measures, right? You're isolating travelers, you're isolating certain ships, you're identifying a group of people, and that involves the social interactions that we would think of as existing within any human society. Now, early quarantines involved and deployed ideas about external threats or sources of diseases. So ideas about trade and migration and travel, but they also involved ideas about internal threats or local concerns like vagrancy, poverty, about minority populations, however they were defined. And so, the imposition of quarantine for centuries really has involved reading those isolation measures, those distancing measures through the lens of the concerns of the society at the time. So they've been very different in history and differently deployed in time. I'm gonna take a drink of water. So this is a summary, and this is this wonderful article that I sent you all from Alison Bashford and Carolyn Strange. We see that historical evidence really demonstrates that quarantines, like other public health interventions, are designed on medical and scientific grounds, but also involve other kinds of social and political and cultural factors in terms of how they're implemented. Okay. So by the mid-19th century, I'm zooming forward in time here, everyone. By the mid-19th century, we've seen a lot of connection globally between the era of the Black Death in the 1340s through into the 15th and 16th centuries. We have transatlantic circulation of people, either the forced migration of the slave trade or circumnavigation of the Atlantic Ocean into the Pacific Ocean. So people are connected. We have imperial relationships, a lot of expansion by the mid-19th century, but also new kinds of ideas about connection in this age of empire. So I want to move us forward to, for the sort of world and European historians among us, to thinking about the late 19th century, mid to late 19th century, connections between metropolitan Europe and the United States and their imperial holdings overseas, and to connections between different groups of people, the flow of goods and people across the oceans over railroads, and the dynamics that we would think of as involving disease in that moment. One of the things that we see in this moment is that it's also a really interesting transition intellectually in science. So this is the mid-19th century and later 19th century is the era of germ theory, the advent of germ theory, which is to say this is when we start to develop ideas about specific germs causing specific diseases and the ability to find those germs under the microscope and to test whether those are causes of pathology in the human body. So quarantines and public health measures become rooted in science and medicine in those ideas, but also rooted in geopolitical concerns. And science and medicine themselves are really politicized in this time period in really significant ways. And I'll walk you through the examples of cholera and bubonic plague to show you talk a little bit about how.
And as you enter that, Mary, I don't want to go too far down this rabbit hole if it takes us there, but are you also suggesting then that there were certain cultural or geographically specific understandings of disease and epidemics and responses to those epidemics? In other words, we're using terms like quarantine in a global sense, but was quarantine different in different places and with different
That's a great question. Yeah, no, I'm really glad you asked that. So yeah, I'm focusing mostly here on European examples, in part because that's where we derive our public health system primarily. But certainly there are what we would think of as being social isolation measures, not necessarily a 40-day prescribed quarantine, but efforts to distance the sick and the well in diverse human social examples. So I'm an African historian primarily, and there are efforts to identify and to manage people who have sort of visibly serious illness, something that changes the body or changes a person's temperament, and to sort of separate those people socially maybe from another group. And this is with regard to the kingdoms of the Great Lakes region in Africa around Lake Victoria and Lake Tanganyika. We also, there are measures I would imagine in East Asia, the sophisticated states in what are now China and Japan to manage social issues and the movement of people and the movement of illness. So absolutely, this is something that's very widespread in human society. And not only with the institution of quarantine. The 40-day quarantine and the kind of specific way that it operates is particular and grows out of that moment with the Black Death. But there are a lot of other ways that people have kept disease at bay by separating the sick and the well historically.
Right. And then as a follow-up question, again, trying to keep it relatively short and direct, we're mostly talking, it feels like we're talking about disease and epidemic that is accidental, is that the right word? Or it's by God's will, not marginalized peoples who contract epidemics because colonists and colonialists move in and weaponize it, right? I mean, we're not talking about,
this is not smallpox blankets. No,
right.
No. But one of the things that we do know, and we see this later on, is that people who have poorer nutrition, who are at the sort of in societies with social stratification, who are at the bottom of those social strata, who are poorer, who are sort of not attached as well to robust social networks, or caught up in like the welfare states that we see emerging in the 19th century, are certainly more vulnerable. They're a lot more vulnerable. So yeah, absolutely.
Okay, thank you.
And that's not to speak to whether they're what I would say immunologically naive, which is to say they're dealing with something they've never been exposed to before. Those kinds of health challenges that we see, those epidemics that we see in the Americas, for instance, with smallpox, with other diseases, have to do with them striking populations that had never seen anything like it before.
Right, got it. Thank you.
Yeah. So what I'm actually going to move through, I'm not going to get much into cholera because I want to make sure we get into the political stuff. Cholera is a disease that's spread through infected food or water. It's also bacterial. You can get cholera again and again. And it's very easy to keep somebody alive with cholera if you rehydrate them with a salt sugar electrolyte replacement, like we would think of as being important for managing diarrheal disease or any disease that dehydrates you. But cholera is important in the 19th century because we see some really interesting shifts according to empire and expanding trade, new kinds of technologies. So just to draw your attention to the map at the upper right, which has the red, right? You saw that first map that Andy put up that had China in bright red. This map is a little hard to read because it's an older map, but that red is highlighted in the Ganges Delta area of the Indian subcontinent, and it labels that as the area from whence Asiatic cholera came. So cholera pandemics begin in the 18 teens, circulating within Eurasia and then globally on trade routes born of empire. But we see cholera labeled as something that is specifically Asiatic, even though after 1817 or so, it's really well established in a lot of different places globally. So these pandemics of cholera circulate. But there is an idea that tags cholera as being particularly Asian, and here Asian means Indian, as something that comes out of the Ganges Delta that's associated with non-Christian religions, non-white peoples, different kinds of political systems, and so forth. Notwithstanding that it's spreading globally because the British are moving goods and soldiers in and out of India at breakneck pace as they're trying to subjugate the populations of India to colonial rule. So it has everything to do with empire. And one of the things that we see, with this is that there are new institutions of quarantine, but also regulations of quarantine and international regulations that emerge in this period in the 19th century. And so this is an important benchmark for us, that when we have empires and broader sort of the nation states as the main unit that we're working with, we start to see coordination both between scientific authorities, but also diplomatic authorities around cholera. So in the 1850s and then again in the 1860s and on through the 1890s, there are international conferences that meet to deal with this problem of cholera and its circulation globally. And what they do is try to figure out how to impose quarantine measures, how to manage illness and surveil illness in port cities, how to monitor travelers, and to see how to sort of stop this problem of cholera, which is at this point a really terrifying disease for people globally. Cholera in the 1820s and 30s on the eastern seaboard of the United States was horrifying for people. They did not know how to keep people alive, and people died in significant numbers. But what's really interesting about quarantine and its sort of big sister, the cordon sanitaire, which is the sanitary cordon closing off of a really big area, is that these international conferences apply quarantine very unevenly according to geopolitics at the time. So even though ostensibly any traveler who was sick could spread cholera globally, European authorities in the 1860s and 70s focused really, really closely on Muslim travelers and on what they see as Asian travelers. So they prohibit people making the pilgrimage to Mecca, making the pilgrimage of the Hajj, or they try to control that Muslim pilgrimage. This is in an era of sort of anxieties about Muslim populations as well. The European powers sort of band together at the expense of the Ottoman Empire and Persia, which are both really important states at the time, to control Muslim mobility in a particular way, even though they allow the movement of European troop ships through the same areas that have the same problems and so forth. And so this just really reminds us that viewing diseases through a racial lens, or what I think of as the racialization of disease, is something that has been with us for a very, very long time. And in fact, was a part of the early institutions, international institutions, that allowed for the management of disease, even prior to something as formal as the WHO or the League of Nations Health Organization in the 20th century. Do you have any? Cool.
Yeah,
I see it.
Yeah, let's pause for a moment. I know what's happening now because it's happening to me, is that all of our attendees, all of our participants are kind of sitting back, just absorbing this sort of complication. But I do want to pause for just a moment, keeping my eye on the clock, and ask if there are questions or comments. Amelia Simpson asks, or notes at least, that Edgar Allan Poe's Masque of the Red Death was probably based on the cholera quarantine in Baltimore in 1830s.
Right, and in the 1830s, there's a wonderful book called The Cholera Years by Charles Rosenberg. Here you go. Oh, watch me try and type fast. Charles Rosenberg, The Cholera Years. That's a fascinating study of cholera in the U.S. in these early parts of the pandemic. So yeah, we see these things in literature, and I mean, I would teach an entire class of epidemics and disease in literature if I could. It's kind of out of my wheelhouse, but I'll talk about there's one book that I think is just a wonderful thing to teach the influenza pandemic with, 1918, 1919, that I'll talk about in a minute. Do you have any other questions about cholera, or about this sort of international dynamic, or about race at the time?
Amelia asks and wonders how the Jews factored into quarantine.
You mean, and I'm imagining we're thinking about sort of distinctions, religious distinctions, if European powers were thinking about Muslim populations and their mobility as opposed to Jewish mobility. You know, I don't know actually, that they were kicked out of cities during the bubonic plague because they were scapegoated as being the cause of plague because of sort of anti-Semitic sentiment among Christian populations. It may have been because they were sick less. I don't know if that anecdotally, that's something I don't know off the top of my head, but I know that in the medieval lens of interpreting the bubonic plague as something that was a visitation from God, the scapegoating of Jews and the destruction of European Jewish populations was part of the European response to that. In terms of these quarantines in the 19th century, I don't know. We do see that Jewish populations are singled out as sort of particularly of concern as Eastern European Jewish migrants come to the US in the 1890s. And there's a great book on that by Howard Markel, who's a scholar at the University of Michigan, and it is just called Quarantine! That deals with the role of sort of American approaches to Jewish migrants here too. Poverty and class, yeah.
Yeah, Michael Reynolds up in Alexandria, Virginia asks if you can speak some about poverty and class and how it plays a role in understanding cholera.
Absolutely. So some of you may be familiar with ideas about early ideas about epidemiology and cholera in England. So that John Snow, this famous physician and amateur epidemiologist who started to map cholera in London, and then correlated it with the use of particular water sources. So this is one thing that is part of it. So poverty and class certainly are important here. One of the things that we see wealthy people do when cholera breaks out is they flee the city because they have the means to do so. And cholera is often associated with poor populations who are stigmatized as being more ignorant or dirtier or what have you. So there are certainly dynamics where people are identified as being kind of sources of disease in the way that we see poor populations, particularly in the US and Europe, stigmatized as being sources of disease. But cholera was an equalizer in a lot of ways because it didn't really care who you were or how wealthy you were. If you were drinking from a water source that was polluted with the cholera bacteria, you were toast. So, so we see there are ideas about it that sort of isolated in particular populations, but that they're also eventually dispelled by understandings about water sources and how it travels. Oh, totally, with the secret garden. Absolutely. That's the first I'd ever, that's the first I'd ever heard of cholera. Little Mary Lennox. Yeah, there's another book by, I'll have to look. It's called Cholera, a Biography. It has a brutally evocative description of what it's like to have cholera, just as an FYI, but it opens up with a connection to the secret garden, to that book. And I teach the first few pages of that when I'm teaching cholera, because I think it's really important for my students to think about the human impact of being really sick, that these aren't sort of abstract. And we still have cholera in the world today. We're still in the midst of the most recent cholera pandemic officially, so it's not academic. Art class, yes, Natalie Alvarez, good idea. Let's try and brainstorm about that as we go. When we get to talking about COVID-19, I'll mention something. I have a student who's trying to develop an art project. So I want to think about, whoops, the mouse is in the wrong place. I want to just take you through some examples with regard to anti-Chinese racism in the US. And just to give a sense of one of the reasons that it's really careful, or it's really important, I think, to be really careful how we deal with and how we engage with anti-Chinese or anti-Asian racism in our conversations around coronavirus, because those of you who are living in California, where we saw particularly virulent anti-Chinese sentiment in the 1880s, and where the sort of memory of this, as well as anti-Japanese racism, was something that's much more front of mind, I think much more openly engaged with. You can jump in here anytime, but one of the things that we see with anti-Chinese racism that has really strong echoes to conversations about Chinatowns as sort of foci of illness in the present day, or Chinese populations, there's really a pretty visible line back to ideas about the threat that Chinese workers posed to American workers in the 1880s, and the institutionalization, the legalization of discrimination against Chinese immigrants in the Chinese Exclusion Act in 1882. The Chinese Exclusion Act is a federal law that was the first use of an ethnic or national group as a defining group in an immigration law. It was a direct response to concerns about American labor and immigrant labor. But it was kicked up to a fever pitch with the third pandemic of plague in the 1890s. Oops, I think I lost a map. Okay, I'll go back. So the third pandemic of plague starts in the 1890s and starts to circulate globally. It's understood as emerging out of Eastern Asia, but it's hopping among port cities in short order. It arrives on the West Coast in the 1890s, and we see Chinatowns targeted by municipal authorities in San Francisco and in Honolulu. Honolulu's Chinatown, and these images on the right-hand side are of Honolulu's Chinatown, which was an area where 40,000 people lived and worked. There was an idea that the Chinatown must be the area where plague was located in this pandemic, because it was something that was coming from Eastern Asia, people believed. So one of the first things that they did in San Francisco was to require all non-Chinese people to move out of Chinatown, which clues us into the fact that there were white people living in Chinatown, but also that it was explicitly racialized, that it was about being Chinese, not about where you lived. In Honolulu, which was home to 40,000 people, there was an effort to cordon off the entire Chinatown from the rest of the city. People's belongings would be brought into the street. That's the middle image there, to be disinfected. Some houses were burned down or sort of burned out as a way to try to get rid of the rats. what happens in Chinatown is that the fire that was ostensibly a controlled fire to get rid of habitations that were understood to be harboring plague spread, and the entire Chinatown burned down. So those 40,000 people were displaced, all of their belongings were destroyed, and that's that bottom image. And of course, what do the rats do? They leave. So the plague harboring rats that had been in certain areas, not only in Chinatown, did spread elsewhere, and we see the disruption of the fire and social disruption leading to the spread of plague much more widely. But the Chinese populations, Chinese immigrant populations, and generations of Chinese descended populations in the U.S. in the 1890s were the targets of violent racism and virulent racism that went after everything from foodways to types of dress to ideas about sexuality and gender norms, to diseases. And diseases in Chinatowns and diseases among Chinese immigrants are one of the primary kind of levers of power that that majority populations used to discriminate against Chinese populations in this time period 130 years ago. So
yeah, it really feels like, and I think you did this intentionally, but it feels like we've moved from what earlier was almost a scientific conversation to now a much more humanist conversation, which is, you know, the ways that these things were weaponized and interpreted to advance these goals. Are we talking more about disease now or health? And is there a difference?
So I use disease and health in juxtaposition in the way that I juxtapose illness and wellness, meaning that we can sort of think of those as being opposite, but that they're linked. So right. These are all, I think these all fall under the rubric of public health interventions, right? So the quarantine measures are international legal interventions that are trying to limit the spread of disease, but they're applied in a way that is sort of fitting with the ideas about race and religious difference at the time. Likewise with these in sort of targeting of Chinese immigrants in the 1890s. There was a long tradition of burning the habitations of people who'd been sick with plague. This is something we see in a lot of different places. But the point is that even though later on in the 1890s, there's a way to look for plague in people's bodies to identify that bacteria after 1896, 97, there are still particular populations that are being targeted, not based on whether plague is there, but based on ideas about these places as plague harboring areas. So, yeah.
Mary, it's my job, unfortunately, to remind us that we have 25 minutes left.
Yep, let's go. Okay, so pandemic influenza, getting back to one of the first questions that we had from Rashida. So pandemic influenza 1918, 1919. So one of the first things I think that is really an important lesson is to stop calling it the Spanish flu. I've written about this in other ways. Spain had nothing to do with the spread of the influenza pandemic in 1918-19. It was just, as a neutral nation in the war, the first to report it. And so this was an H1N1 influenza. We know the strain now based on research.
Hold on, yeah. Mary. You've just exploded 50 state curriculum right there. You're
sorry.
Telling, don't call it the Spanish
flu. Stop calling it the Spanish flu. Okay. It's easy. It's hard not to call it the Spanish flu, but it had nothing to do with, there was nothing Spanish about the Spanish flu. Yeah. Here's another one for you. Our best estimates are that the pandemic influenza in 1918-19 started in Kansas.
Kansas, U.S.?
Yes.
Good, thank you.
Yes. So, it's fascinating. Yes. So yes, Mike, I agree. It is an interesting story it is a teaching moment to explain why you call it the Spanish flu. I totally agree. It gets us into politics and everything else, but I think that I feel very strongly about this when I argued that we have to stop calling COVID-19 the Wuhan coronavirus or the Wuhan flu, because there was nothing peculiar about Wuhan that led this to happen, and that can have devastating impacts on the economy of a city or of people in the long run. So that's not what we necessarily see with Spain and the Spanish flu, but it just clues us into thinking about, why do we call diseases certain things? Why do we name them after places? Juliet, they called it the Spanish flu because Spain notified the world about it. Basically, Spain talked about the fact that it was there and affecting people, and that then led to the labeling of this particular flu as the Spanish flu. So one of the things I want to point to you here, and why we think about H1N1 in 1918, 1919, is to point you to this curve, which some of you may have seen already. Most seasonal influenzas have a U-shaped curve. So if you imagine a U shape instead of a W shape on this graph, and that U-shaped curve represents that the people that are the worst impacted are generally the very young and the very old. And in 1918, 1919, we saw a W-shaped curve, which had this uncharacteristic peak of mortality for people in the prime of life, right? So in their 20s and 30s. So we saw generally higher mortality than you would have anticipated in young adults. This exceptional virulence of this particular strain for particular populations. One of the reasons why talking about influenza and COVID-19 in the same sentence is, I think, something we have to be really deliberate about and really careful about, is that this mortality curve, which is part of the reason that epidemic influenza was so dramatically terrifying for people, because you had demobilized soldiers, people who you would have expected to be healthy, that were falling ill. This is not at all what we are seeing right now with COVID-19. The influenza pandemic also moved really quickly, really fast, in a way that is also not representative of the way that we're thinking about mortality with COVID-19. You know, percentages of mortality, when we talk about the total case fatality rates, is something that we will know in time about this current outbreak, whether it's comparable to pandemic influenza or not, but we don't really know about it. There's also no treatment, no antiviral, no nothing, and really spotty prevention. The desire to not hinder the war effort or to panic people meant that you know, there was a parade in Philadelphia that was allowed to go on as planned, even though there were sick people in the community. And John Barry has written about that very evocatively, who's written, and I'll put some of that in the bibliography for you all later. As for that I opened the window in influenza. I play some of the American Experience film documentary for my students sometimes, and they always grab onto that too. It's, I mean, the documentary sort of plays it over and over again and you hear it, but it is totally there. The difference between the red and the white line, the influenza attack rate, that's the influenza attack rate. So that's to see sort of who was impacted by it. And I generally I won't talk about the attack rate right now, but rather just about that, that up and down, that W-shaped curve. Another thing that I would suggest if we're thinking about teaching these things through literature, the Mask of the Red Death and such, Catherine Ann Porter's novella, Pale Horse, Pale Rider, is a wonderful and really gut-wrenching recounting of her own illness as a newspaper woman in Denver, as a young woman, from influenza, the death of her boyfriend at the time. Boyfriend sounds sort of casual, but they were pretty serious, I think, and just her experiences of illness. And I've taught this alongside stories of pandemic influenza in my classes before, when I've been able to dig in on this a little bit more, and it's been really interesting for conversation. Just to give you a couple of ideas, international coordination with H1N1 is not at all robust. There is no League of Nations, let alone a World Health Organization, and it is actually the poor response and the inability to coordinate that is one of the things that factors into the League of Nations Health Organization's advent in the 1920s. There are local isolation and social distancing measures. Social distancing meaning closing of churches, closing of movie halls, encouraging people to stay at home. and isolation of the sick, but it happens so fast and people get sick in a matter of weeks, hundreds of people, thousands of people, that really it's a question of sort of how to keep up. We are not in a situation that we would identify as being similar to this at a global level. Another thing that's important to remember as a difference with pandemic influenza is that we see hundreds of thousands of people die in the United States, but the mortality rates, which are dramatic, 50 million people worldwide, are generally clustered or generally located in not in the US or Europe, in other parts of the world. So that's something else that's important too. Social distancing at a state level, do you mean like individual United States, like Pennsylvania versus Colorado, Jamie? Or maybe thinking about national governments, I don't know. The other thing that's complicated about H1N1 in 1918 is that the individual states address this differently. So the national response in the US is pretty spotty. Oh, why Andy and company can't come to Los Angeles. I don't know about that.
Sorry, Jamie. That's because of my boss.
Yeah, that's one of the things that we see with this. But these are measures that are kind of similar to the way that we would think about a quarantine, but they operate slightly differently. So I'm going to move through recent points of engagement to give context for COVID-19. One of the first things to keep in mind, or things to think about, is how do we see diseases still being racialized? What are the consequences of associating particular populations with particular diseases? And what are the kind of different ways that that is done? Emphasis on wet markets or live animal markets, emphasis on dense populations and so forth. I mean, sometimes these are really thinly veiled ways of talking about racial or cultural difference rather than talking about the actual problem, which is a public health infrastructural problem, which is a problem of disease surveillance. And when we think about key lessons, that's something I'll try to get through here too. So SARS, severe acute respiratory syndrome, was really the kind of first coronavirus that really woke everybody up to thinking about these. It was named SARS before the coronavirus was ID'd as the pathogen, this particular coronavirus. One of the things that we see with SARS, with a timeline, SARS was relatively brief in total. We know that the first cases of atypical pneumonia developed in 2002, in November 2002, and by June 2003, the outbreak had been stopped in its track through an exceptional work of surveillance and containment by national governments as well as the World Health Organization. But SARS was very different than the disease that we are dealing with right now. It had a 10% mortality rate, high mortality rate. That means 1 in 10 people died. It was totally new. It also had a different kind of incubation period that made it easier to stop, easier to track. But it spreads very rapidly in Southeast Asia and then moves to with travelers to Canada. There are a lot of miscommunications and reorientations in the first few months. Concerns about transparency, tensions between the WHO and China and internally in China. But ultimately, what we see with SARS is this really kind of heroic containment measure. But one of the things that I think is an important analog for all of us in the United States are the experiences of Chinese Canadians in Toronto. The Toronto SARS epidemic was focused primarily in, there was a hospital context where it spread very rapidly, but its association with travelers from East Asia led to wide-ranging stigmatization and impacts on people who were understood as being Chinese or Asian. So there's a wonderful set of oral histories with people at the time. Filipino home care workers are summarily fired by their employers. You have the kinds of stories that we are hearing and maybe seeing around us of avoiding people on the bus or being worried about mask wearing are really kind of in overdrive in Toronto. And so that has really significant social and economic impacts, as well as really significant impacts on healthcare workers. So healthcare workers who are active in working with populations with SARS, who were in the trenches, were suffering dramatically from illness themselves. It was very efficient at spreading in hospital contexts. but also people were terrified that they could be infected as well. And so we saw this a really traumatic experience for healthcare workers who were at the front lines of this new epidemic that was behaving in a way that nothing anybody had ever seen before. And so those consequences for healthcare workers are also something I think we have to be thinking about. This is a really stressful time for people in that context as well.
So Mary, I've been saving this question for this point. I'm gonna back up if you don't mind and just ask this question now. How can you map what you've been describing on the communication and sort of instantaneous digital landscape that we're in? So early 2000s, you used words like terrifying. Well, terror spreads when you talk and people text and they share and they know. And so how is this mapping onto the sort of the social network as well?
The landscape at the time. I mean, newspaper coverage was at a fever pitch. You would have had television media and so forth. Like this is sort of early social media, early internet. Like, of course, we have email and such, but not the kind of instantaneous platforms like we do with Twitter or Instagram or Facebook. So the landscape in that sense is quite different than what we had today, but we still saw the kind of policies that were oriented around travelers, and the way that the media picked up that, so that Toronto's Chinatown is deserted, and while there's an intense concern about tourism in Toronto that leads a Canadian delegation to go to the WHO and ask the WHO to please reverse its travel advisories against Canada, which they do after only a few days, but the resources aren't necessarily channeled to Chinatown, where they're the most needed in the aftermath, because people stay away. So I don't know if I'm answering your question exactly, but there are a lot of different ways that this resonates in terms of how people are talking about this current coronavirus, even if they're not really thinking about it.
Yeah, and without taking up too much airspace on this, I think it's, I'm struck by the term viral and this notion of the ways that we imagine and roadmap and assign disease, which is a very objective sort of thing. Seems to shift in the 21st century, and now that we're in coronavirus, is that sort of the tip of the spear of what you've shared with us so far?
What do you mean by that exactly?
Meaning again, we're sharing so much information so quickly, whether it's right or wrong. That all the things you've outlined, all the elements of previous epidemics are sort of crystallizing in now, and we're sharing it in a much different kind of way.
I mean, I think that I'm wary of saying that like this is the be all end all of everything that we've gotten right or wrong in the past, right? But I think that some of you may have seen that there was a photograph, an illustration that was used, I think it was in the New York Times, I don't recall exactly, describing coronavirus, I think in New York City, and the picture was of a man sitting on what looked like a subway, and people very quickly pointed out that it was a man on the Hong Kong metro, not on the subway in New York, and so this sort of stock imaging of this as an Asian disease is something that is I think a really significant thing to be wary of. We have to be able to talk about how and where zoonotic diseases emerge into human populations, which happens everywhere, right? We're looking for them in particular places. But we have to be able to talk about that without making this into something that is about race or culture, right? So opportunities for transmission of viral diseases from animals into humans, do have to do with population density. They do have to do with how animal husbandry and traditions of animal husbandry. But if we are, if we don't manage to find a way to be critical about a sort of zooming up to associating diseases with entire populations of the globe, we're just in such dangerous territory, and it's so damaging. I mean, my students have been talking to me about the impacts that they've felt, when they ride the bus and clear their throat, and a person looks at them out of the corner of their eye just because they're perceived as being Chinese.
Right.
This is something that we can really work to do better on. So one of the other things that I wanted to sort of point to, if I can give some context for coordination at the WHO level has been really important. I think I probably won't get into talking about Ebola, even though it's one of my favorite things to talk about and teach with as a person who works on African history. One thing that has been a topic of conversation is whether this should be classified as a pandemic and what it means for this to be a public health emergency of international concern. And something that I wanted to clue you all into and give you a kind of sense of is that designation of the PHEIC is actually very, very new. We've really only worked with the PHEIC designation since 2005. And it's a designation like declaring a state of emergency, which allows people the WHO to mobilize particular resources. It requires reporting by member nations, so it helps with monitoring disease. But then it also allows a convening of an expert committee that will address this particular problem. And we have the PHEIC in part because of lessons learned from SARS in 2002, 2003, where we didn't have the same mandated reporting structures. We didn't have the same kinds of emergency expert powers or powers of convening emergency expertise as we do now. They've been refined in these international health regulations from avian influenzas in 06, 07, and then H1N1 in 2009. So when we talk about the PHEIC, part of the reason there's so much discussion about what it is and how it works is because it's new. But that's a good thing that we have it. It's a good thing that we have that institution, and it's not been used very much. Only, I think this is the 7th instance. H1N1 in 2009 was the first, and then polio 2014, Ebola, Zika 2016, Ebola 2019, and now with coronavirus. So just keeping in mind that that we have sort of work to do to explain how this emerged as it has and why we talk about it in the way that we do. One of the other things that I want to point to, I'm going to go through Ebola and just talk about these things as recent touchstones. One of the things that I would argue is that most people are putting this coronavirus outbreak in the context of movies like Contagion, movies like Outbreak, games like Pandemic, for those board game players out there.
Walking Dead.
Right, well, yeah, Walking Dead, any zombie movie of your choice. But I think also part of the question about this, or the sort of concern, has to do with the media coverage of Ebola virus disease in 2014-15, even though they are dramatically different kinds of diseases, even though we have a very different approach to both of them. And even though we learned really valuable lessons in terms of the global public health context around sort of what to do and what not to do from Ebola. And one of the key intersections from my perspective was the early focus on consumption of exotic foods or foods that were understood as exotic, the so-called bushmeat example. That this coronavirus emerged from people eating exotic wild animals they shouldn't have been eating. There were early conversations with Ebola virus disease about the consumption of monkeys, which was completely erroneous and had nothing to do with the outbreak. But that just clues us into the kinds of cultural processes that are going on, right? Why is it that we talk about the ways that people eat and the food that they eat without any factual basis, really, when we're trying to understand a disease that we think of as being from someplace else, right? How is that sort of discussion and discourse putting distance between people rather than understanding, the different conditions that we're all dealing with? So we see these as really important reference points. SARS as another coronavirus with impacts on the Hong Kong and Chinese economies and anti-Chinese racism, but also concerns about transparency and reporting, both from within China as well as action at the WHO level. So, so these kinds of conversations that seem to be, or probably are for most people, quite new with regard to transparency and reporting and surveillance, have an extensive history if we're thinking about the way that the WHO operates in this time period. Likewise with Ebola virus disease, when we're thinking about the reduction of travel and difficulty moving essentials, sort of making this exotic and foreign and a panic that's out of proportion to most people's actual risk. I think this is also important. I think we should start basically sort of ban bushmeat from our lexicon and just talk about meat that's hunted. We're going to call meat that people hunt in other places bushmeat. We have to start calling venison bushmeat. right? And I'm from a place where people hunt deer, so I know what kind of shot I'm firing across the bow there.
Right.
So when we focus, the sort of takeaway here is that when we focus on the exotic origins of a disease or particular populations as carriers or as responsible, this increases stigma, it increases racism and discrimination, and it increases panic. And it also doesn't encourage people to think about their actual risk, which by all accounts was low in the case of Ebola, but that didn't stop people from canceling trips or being worried about it. You know, we have to pay attention to what your county and public health authorities are saying about actual risk, rather than focusing on this as something that is coming from somewhere. And because it's coming from somewhere, it's deeply sort of more disturbing. But I think this also is a really interesting way in for us as educators to sort of query the kinds of ideas that our students see in circulation. You know, sort of what is it that seems intuitively logical that people are willing to retweet something that they have no basis for understanding whether it's factual or not. You know, what is it that we're kind of tapping into in terms of ideas about disease and about difference and about other things. And this is another thing to just sort of point to the kinds of impacts that we can see with quarantine and isolation, those sorts of issues with the sort of cultural contexts that we've seen in the past and continue to see in the present day. I've included here some links, resources. There's a wonderful WHO Q&A on COVID-19 and advice for the public. The CDC has a great series of, WHO has a great series of videos and infographics. If you're working, I have a sort of how COVID-19 is transmitted primer that I've given to my class based on a minute-long WHO video that's really good at indicating what you can do to stay healthy. And then I think an article that I've found useful for just thinking about how we talk about science, then the Lipsitch and Hanage article that I have cited here on reporting the COVID-19 outbreak responsibly is really good in terms of thinking about how we are scientifically literate and so forth. So yeah, Amelia, when you say that if your students ask you if they're worried, you tell them you're worried about how people are responding, that's absolutely what I talk about as well. But we have work to do to give them more information. So I think we've rounded it out now. Please feel free to be in touch if you want to. I've recently joined Twitter and tried to only retweet good, reputable information, so you can follow me on Twitter. And if you have any particular questions about any of the resources that I put up or anything, I'd be happy to answer those, and you can absolutely reach out via email. But thank you all for your attention. I really appreciate it. And you'll see more source material that you can bring into the classroom in short order as I kind of assemble what I think you can work best with. Andy, hello? Shit, did it really time off?